So we have one last case to share with you. This is a case that we included in the Absorb trial. As you know, we have three institutions in Brazil randomizing patients.
No, I won't do it. Just measure the gradient that we didn't do.
Which is Einstein, Uberlândia, and Dante Pazanese.
Yeah.
So
just finished.
Jose is going to present this case so we can discuss.
Good morning, Fausto. Good morning, Mari. Good morning, everybody. After this beautiful demonstration of TAV, we are going to switch to a coronary case in a topic that is still a bit provocative, the use of bioabsorbable scaffolding. Breno will help me with the slides. Breno, if you could please go to the next one. Okay, this is the case of a 47-year-old male patient. It's important to stress it's a very young patient, it's 47, that came to our service. His physician referred to us. This patient had a typical class 3 stable angina for the past 5 months. He did in another service a MIB, a scintigraphy that was positive for ischemia in the inferior wall and in the anterior wall. But we don't have the image because it was not done in our service and he couldn't recover the image, just the typed the description of the results. This patient has hypertension, diabetes mellitus type 2, was a smoker, and another risk factor was obesity. His body mass index was 29.6. His physical examination didn't have anything important, and no other important findings in his examination. With this history and these risk factors, we decided to do a cardiac catheterization to have a full idea of his coronary. Breno, next please. Okay, this is the RCA, and as you can see, he has a pretty tight lesion in the proximal to mid portion, the transition. It's a long diseased segment. Although the critical point is focal, there is disease that extends to more than 25 millimeters, as you can see. And the flow is a bit impaired. It's, I would say, Team 2 flow. Next, Breno, please. There's the still image, so we can appreciate better. And the LAD, as you will see, also a, not critical, but I would say at least 70% stenosis, with some calcification at the proximal part where the stenosis is located. Next, Breno.
Can you see the image clearly at the auditorium?
Yes, very well. It's very clear,
Wonderful.
and the microphone now is fine.
Yeah, we can. It's a little bit hard to tell how severe that prox LAD lesion is. At least from that one shot.
Okay.
I agree that it may be severe, but...
Well, based on the angiographic findings and with the MIB, the scintigraphy that he had showing ischemia in the inferior wall and anterior wall, our initial thought was we planned an intervention to treat the RCA and the LAD. I don't know if you want to discuss this, if you want to make any comments.
So it's a two-vessel disease patient in a young 47-year-old diabetic patient. Any thoughts? Should we do syntax, talk to the surgeon, or those are essentially two focal lesions and a young patient would go ahead and intervene? What are your thoughts from the panel?
I'll expose myself by saying I think it's good to talk to the surgeon, but in this case I would be talking about the weather or about the football scores. I would not be talking about bypass surgery.
Yes, Roberto?
In this case, Alex, I think there are two key points. One is side branches and the other is the tapering LAD. And again, the sizing of this scaffold device is completely different from our current practice for metallic stents. And then you have here a very teaching case so that you can share with us what are your approach for these topics, mostly sizing of the device and the tapering of the LAD. How do you approach this with the scaffold device?
Well, I would say also that both of the right and the LAD, you probably are going to be crossing significant branches. So I think that the issue of side branch access is something you have to think about. And there's also some calcium, not trivial calcium, in that proximal LAD. I would add those to your list of important things to think about in a case like this.
So would you do a FFR in LAD in this case, Patrick?
Yeah, I think that the LAD is a good case for an FFR, but not a static FFR. I would do a pullback to pick up exactly where is the gradient. I believe we assume that is the first lesion, but you never know. But that's the way to do. Another way to do is if you have done a multi-slice CT scan the day before and you have your heart flow, you can on your iPhone scroll along the vessel and look the FFR. That's a new method. Yeah.
Yeah, I think that's very exciting. Someday we'll have a supercomputer in our back pocket and we can do it. Yeah, no, the right is obvious. The LAD, I think you're right, Patrick, but there's disease further downstream as well. So if you did FFR, I would be doing an FFR pullback as well, just to see if most of the drop is right at that discrete lesion.
For the right ventricular branch, I mean, it could be an issue, but it's not forbidden to dilate a side branch. It depends a little bit what technology you have with the bioabsorbable. There are at least 6 clinical in use now, so each has its technique. But in the case of an absorb, and here it's an absorb in the absorb extend, what you could do, you could use a balloon of 2 millimeters. You should avoid the kissing. The kissing is what is going to disrupt the device. The device, you have a leeway of 0.5 millimeter, but the new temecula is a little bit more, 0.8 millimeter. But kissing is not the thing to do. It's really open with a single balloon, which is clearly undersized for the main vessel. And then there have been some beautiful cases. I think I'll show that tomorrow with OCT online, 3D OCT online. So really you select your cell, not the proximal, not the distal, but the central, to be sure that you do a good dilatation. And I think that's one of the tools of the future. I mean, the computation of the 3D OCT is so fast now that you get the image with your Y in the one of the 3 cells, and then you reposition. We still have to find a way to reposition systematically, but at least we can see it.
So the Kuput lesion is the right coronary artery, Marty. What do you think? Just treat the right coronary artery, take the patient off the table, and follow clinically and do like a ischemia test or something like this?
Well, they've already done a stress test, and there's both inferior and anterior ischemia. Yeah. It's class 3 angina, so I think there's probably something in the LAD as well. And, you know, a case like this with 2 vessel disease, I think they can do it all at once. The right coronary is also interesting because, as was mentioned by Dr. Costa, it's a tight lesion, but then there's this long shoulder. So the actual disease is over a long segment. So I think with a scaffold like this, you'd want to cover pretty much normal reference to normal reference. So you'd be using a longer device, yes, you know, than is this lesion, is what my guess would be.
So Alex, what are your
perfectly
plans?
Correctly, that's...
So we really appreciate the discussion, but you know, we agree that with this positive nuclear medicine, anterior wall, inferior wall, and it's relatively simple case, not to stage. So we went ahead and deploy a couple of absorb, and Jose will describe.
Breno, could you please move 3 slides ahead, please? This one, yeah, thank you. As was mentioned by Dr. Serraz, this patient was included in the absorb extend. There's a kind of real-world registry with a bit more cumbersome case as compared to the cohort A and B that were kind of first-in-man evaluations of the device. In this absorb extend, the inclusion criteria is a bit more wider. It's a non-randomized study. It's a continual registry. The PI, one of the PIs is Dr. Abizai, that's here with us. And the next one, Breno, please. The beauty of this study is that there are some subsets of patients that will be evaluated with MSCT, with OCT. There will be a group of about 100 patients that will be treated with this device in the setting of acute MI. And for this specific case, there is a subset of patients that will be treated with 2 stents with overlapping, because we are right now very much interested in what happened at the segment of the overlapping as well. And I think this fulfills also the expectations of Dr. Leon, that was expecting us to treat a longer segment from normal to normal. Breno, next please. As potential benefits and advantages, Dr. Serraz has talked to us this a lot, the potential benefits of this new frontier. It restores the vessel reactivity. There's the inflammatory response that occurs is stimulated for a shorter period. Makes any type of future intervention easier, especially when we are thinking about a 47-year-old diabetic patient that probably will have more interventions in his future. And it's, as we'll see along when we move along with this case, it's comparable with non-invasive imaging for follow-up. Next. It's very important to stress this part that the QCA had a very important role in deciding and select the patient for the case. There is the Dmax concept. We have to measure the Dmax proximal and distal to select the device, as well as to access the extension of the lesion. The Dmax was obligatory, was mandatory for the cohort A and B, but for the extend, there are some sites that are doing based on Dmax, but other sites were allowed to do guided by IVUS. This is the Dmax just to illustrate how it is calculated, proximal and distal. This image, after go to car dialysis, they have to analyze this to see if we are in the range. If it doesn't match the inclusion criteria by the Dmax, we should not include, or we should include based on IVUS, if it fills the IVUS criteria to include. In this case, we had a 241 distal, a 271 proximal by QCA. We did IVUS. This patient was suitable. It was close to 3 at distal and 3.2 at proximal. So we decided to go ahead and include him in the absorb extend. Next, please, Breno. As suggested, we did a pre-dilation, a bit more aggressive with a non-compliant 3015 balloon at 12 atmospheres. Next, please. And then we implanted the first scaffold from distal to proximal at 3018 at 10 atmospheres. Next. And the second scaffold with overlapping at 3018 at 10 atmospheres as well. Next. Where I didn't show, but we used the same balloon to post-dilate, and this is the final result.
Perhaps Patrick could make a few comments on the technique for deployment, that we have to go a little bit slower than what we do with metallic stents, and the fact that we have to be a little bit more aggressive with pre-dilatation. Patrick, can you hear?
Yeah, sure. Certainly the concept of preparation is going to become important. I mean, we are discussing that intensively with Antonio Colombo. Sure, calcified lesion could be pre-treated with rotablator or cutting balloons. So the concept of preparation is increasing concept. After all, it's just a scaffold, it's not a stent, so you have to respect the capabilities of the device. The second point